Yes, we're back. Can you see us?
We can see you, and we definitely can hear you.
Excellent. Sorry, this means my voice was too loud. Sorry for that.
That's okay.
Can you show us the patient, please, slides, please, our case. Okay, next slide, please. So this patient is an 86-year-old male patient. He's non-diabetic, hypertensive, ischemic, as you're going to see shortly on the fluoroscopy. Multiple comorbidities, including he's a renal stage 3 patient. History of cataract and surgeries. And actually, he had admitted to the ER with dizzy attacks and near syncope, and no one discovered what is the reason behind it. So they did an ECG, and can we show the ECG? Next slide, please. And this was the ECG. Any comment from your side? When you look at this ECG, in an 86-year-old complaining of syncope, I think you get worried. Do you agree with me? From the panel, that the audience?
Yeah, we are
worried. You have a
worried.
68-year-old. Yeah, exactly. You have a clear, almost trifascicular block, and a 86-year-old, he's coming to the ER with syncope. So that's why the patient was monitored. Next slide, please. And clearly, this was the reason behind his syncope. So, and actually, this was repeated several times. So that's why we decide, according to the age criteria, according to the comorbidities, the leadless pacemaker will be the ideal for him. Do you agree with me?
The panel is agreeing with you, but I think Hikmet is asking, because he's an older gentleman, are you concerned about the higher incidence of perforation with leadless pacemaker?
We're concerned about the incidence. I will not say higher incidence. I will be concerned about the incidence of perforation with any procedure I'm doing, because even if you're doing a pacemaker, you have to be concerned about the possibility of perforation. But the issue is that we have to be meticulous in the case. So that's why we need to look at different views to make sure that we are facing the septum in order to avoid such complication. I know the mechanism here is different. It's not tines and hooking, and we have to screw. That's why we have to spend extra more time, especially when I show you the images, the heart is a little bit rotated. So actually it's not a straightforward procedure. So this case is just specially for the 6th GulfEPLive.
Okay.
Dr.
Can we show you the first fluoro? Can we review the fluoro?
Dr. Mohamed Magdy with you from the panel.
Just leave it here, leave it there. Okay, please.
So what is the echo for this patient, his ejection fraction?
He's normal. He has a normal ejection fraction.
Okay. So this is very important.
We don't put leadless for a patient with impaired ejection fraction. We cannot put leadless for a patient with impaired ejection fraction, because simply we will not allow VVI pacing in a patient with impaired ejection fraction. So unless the patient has a good ejection fraction, you agree with me?
I agree, yeah.
So please.
Yeah.
So the first step is uploading the device. It's not like the Micra when Dr. Yahya and Dr. Raid was showing you that the device becomes loaded with the Micra. So this is the first difference, and this was, we had a chat about this, because the leadless from the AVEIR, it comes actually separate device, and you have to upload it. And you will ask why you have to upload it. Why we have to upload it, Dr. Raid?
Well, you know, this catheter will be used, the same catheter, for actually delivering the atrial leadless pacemaker. So instead of wasting two catheters, we upload it to the catheter, and we can use it again for the atrial lead or pacemaker generator when needed.
So after this, flushing is very important, because we have 4 ports here, A, B, C, D. This is very important step, the proper flushing. And after, we have to cover the device till we go inside the patient. We will show you. Can we play it, please, here? As you can see, this is the device. We unsheath it, so it will be active, because actually it gets active by exposing to the blood pool. Once it's contact with the blood, you have to ask it, the technician who is helping you, and I'm sorry I forgot to introduce the whole team, but I think by now you know all of them. But we have extra from Abbot, we have Fadwa from Abbot, and we have Rory from Abbot as well. So this is, you have to contact them and ask them to activate the device, which is automatic, but they have to stand on the programmer to make sure it will be active. Once it's active, you have to cover it again to ensure safety. Then you have to cross the tricuspid valve, which is quite challenging here. When you can see the position of the temporary wire, you have a feeling like a road map. It's not going to be an easy procedure, because you have like a dipping across the tricuspid valve. Again, you can see the RCA It's like a metallic jacket thrown in front of you. Yeah, for the time being, you have any extras, comments?
We use conductive transmission, so that will actually allow for conserve the battery here, instead of inductive transmission when we do the communication with the programmer, by the way.
And as you can see, during manipulation, he gets very frequent arrhythmias. That's why I stop in between to be very gentle as much as possible, to position my catheter. And each time I look in REO and LAO to make sure that I will be facing the septum, and this to be followed by injection of contrast to make sure that I am facing the septum and I'm away from the apex, in order to avoid the question that was asked by Dr. Hikmat, which is perforation. Can we have LAO, please? So see, when you look at this, you're not happy at all, right? I think you agree with me. I don't like it. So can we go again? So if you screw the device in this location, you will have a perforation. So you have to go back a little bit tilt, maybe a little bit of rotation. But again, we have to be careful because this gentleman is very arrhythmogenic myocardium. LEO again, please, and let's see how. So here it definitely is a little bit much better. I will not say it's optimal, but at least I think we can say we are on the right track, right?
This is LAO.
LAO. So we will inject contrast to see, because so see, I don't like this place as well. What do you agree, Dr.
Yeah, we try to be a little bit higher and more subtle. It's going to be very tough with this patient. I agree.
Yeah, manipulation is very difficult here because of the heart is rotated, as I mentioned. And something which is very important, guys, was AVEIR. You cannot place it high on the septum because the device is too long. It will create problems with the tricuspid valve. And for the future, inshallah, hopefully, when we plan to upgrade the device with another device in the atrium, in order to communicate together, you need the space. So the optimal place to be on the low septum, not in the mid septum, not on the high septum, but to be on the low septum. So it will take us, I know, a little bit more time to find the sweet spot that we are looking for, but we have to try. So patience, patience, and patience. Okay. This is more like it, to be honest. This is more like it. This is the best.
I think this is, yeah.
Yeah. This is very nice.
Okay.
No. We need, okay. REO first. Okay, REO injection. Okay. REO. We will inject in REO and LEO. You cannot only rely on one injection. So this is very important.
So we are away. Are we LAO?
Yeah.
You want to do this one?
REO, yeah, we can.
Okay.
Go ahead,
Okay.
go ahead, Dr.
Okay.
This is good. This is much more like it. LEO, let's check LEO. Please, patients moving. Just we need 2 minutes. LEO.
Yes.
Okay, excellent. We can inject again.
Okay. We have this contrast. Thank you. Oh, sorry.
No, that's
You okay?
Yeah.
Okay, here we go.
Yeah, this is much more like it, to be honest. Much more safer. So at this stage, Dr. Raed, if you can just hold like this. At this stage, we will do the mapping process, which is a great advantage that before screwing, you can map the area. So what we do, we release a little bit the tension on the system from the handle. And now I will unlock, and under fluoroscopy, I will unsheath. As you can see, I'm going back up till here. So now we can ask our technical team to show us on the programmer the mapping and see what we have. Can you tell us the mapping, please? Programmer is connected, right? Can we display the programmer from Abbot? Okay, excellent, guys. Thank you so much. So now you can see the programmer, and actually this system, it's not like real time as you used to with a regular device. It takes like snapshots, and it will tell you the current of injury, the impedance, and the threshold. So this is very important. So it will take like a camera snapshots. Even the programmer, it's not the regular programmer. This is a unique programmer link system that we use with special electrodes with a special positioning on the chest. So this is very important point to keep in mind. It will not work with your regular programmer that you're working regularly. You need to have another programmer. Now we are waiting for the data. So what is the current of injury? Because I cannot see the... Okay, which is good, okay. Let's check the impedance. So 450, which is very good. Okay, let's check the threshold. And Dr. Wright, from your expertise, like if you had a threshold which is not that good, which I mean it's like 2 or 3, what you notice with AVEIR? You will reposition away, you will wait some time?
Actually, after you deliver it, it's customary to be really significantly increased and will come down. So definitely you have to wait.
I'm not sure, guys, if you're at the exhibition, went and visited Abbot and Medtronic. They have a simulator and a device. You can actually see it, and you can just imagine the current of injury from the AVEIR device. So that's why I think it takes 24 hours for its recovery. So we came with a pattern. If the values is improving after 5 minutes and after 10 minutes, this means it's going towards improvement. So hopefully next morning everything will be fine. But after 5 minutes or 10 minutes, if it's not improving and it's getting worse, I think you should reallocate. This is from the experience that we developed from our procedures. You agree with me,
I
Dr.
agree. Very reasonable, yes. You're still, still.
We can accommodate one quick question at this stage if there is any question related to what we mentioned. See, it's capturing, which is okay, good.
Is there some oversensing? Some V-sensors?
Yeah, there was some oversensing, yes, correct.
Totally. And by the way, I'm not sure, Dr. Rod, what is the oldest patient that you did? How old in Saudi?
Well, for the leadless,
yeah.
For the leadless, it was a micro patient in the mid-90s, 95.
Wow. So I stand still. We hold the record, you know. We have 109. Okay. So we have 109 patients with leadless pacemaker, guys.
Okay.
Our threshold currently is less than 2. This is excellent for the AVEIR, by the way. Even if we had it at 2, next morning it will be less than 1, inshallah. But again, it's even still pacing, it's still capturing, which is very good.
Professor Mohamed,
now we lost, yes.
This is again Mu'taz from the panel. I was...
yes, please.
Yeah, I was re-questioning the...
I think you lost there.
The threshold of ejection fractions for which you implant a leadless pacemaker, because you know the incidence of RV dysfunction in the general population of patients is around 20%. But what about those who have fair ejection fractions, or let me say around the 50% range? I think the incidence is very higher than that. In our experience,
I think, yeah. Go ahead, sorry.
Yeah, so patients, for example, who have quote-unquote 50% ejection fractions, or who are considered to be preserved ejection fraction in the range of 50 to 55%, the incidence of LV dysfunction is pretty much high. So if you implant this leadless pacemaker and then you confront with deteriorating ejection fractions, what would be your policy? Or what
Thank you so much for such a wonderful question, especially when we are using this technology. Simply, if this happened after 1 year, I will upgrade it to dual chamber. I will bring another AVEIR and put it in the atrium. So this is what's nice about the technology, that you can upgrade it. So if you're following up the patient, and keep in mind, we are very meticulous when it comes to the leadless technology. I think you heard our colleague, Dr. Michael, we're approaching almost 190 leadless pacemaker. Our mean age is 74.5. This is the age that we are implanting. So as I told you, we have multiple trials, even coming from the UK lately, comparing patients above 75, whether they have VVI or DDD pacemaker, a 5-year follow-up, it didn't make any difference regarding the ejection fraction. The trial that you're referring, I think it's good that we have Dr. Waleed from Cleveland Clinic. It comes from his center because they mentioned the incidence is less than 12% after 5 years. So still, we are putting it in an elderly population, we follow up them, but having an upgradable technology, I think this is a great add-on. So now I will summarize our parameters. I have to tell you this because we have a R wave of 8 and we have a capture of less than 1, impedance of 450. At this stage, we have to take a cine, like the one we took, and we need to show it because we will fix the device now by rotation, and we have to see this marker on the fluoro. I hope you can appreciate the marker, which is like a V shape or 7 in Arabic language, as you can see. And this is this marker, when we rotate and come back to the same level, this will be considered as one rotation. And once we reach that level, we will make it another half turn. So this is 1.5. But this is a bit tricky still. We have to do it bit by bit because this movement from our hand, or Dr. Raed's hands, who will do the pleasure, is transmitted all the way. So you will not like rotate very quickly because you need to see the pattern, how it will rotate. So now I need you to zoom in, please, on our handle. Dr. Raed, you can zoom in.
I want to just comment on one thing. Show us RAO, because you want to see, how much pressure Dr. Magdy is doing. It's not like the AVEIR, not like the micro I told you. Just you want good contact, not too much pressure on the cath. This is perfect. This is something completely different than the micro.
So Dr. Raed was referring to the gooseneck that we mentioned. No need for gooseneck when it comes to AVEIR. No, so now we will fix this as our roadmap. So we need to fix the cine, please, as a marker for us.
Okay.
We need 1 minute. Huh? Okay, so fix it, please.
Up.
Okay.
And now we're going to start.
And we will start.
Okay.
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 And now we are rotating very carefully, very slowly. No rush at this stage. As you can see, Dr. Raed's hand. Gently movement, bit by bit, and see how it behaves.
You want the torque to be transferred.
Now we did 3 clicks, and it's not about the number of clicks. It's about 1.5 rotation. Keep this in mind. So we keep rotating. It started moving a little bit. Yeah, it started moving a little bit. Okay. Again, move nicely upwards, as you can see. Again, moved. Excellent.
Yes.
This is half a turn. One more turn to go. You see his hands very carefully. He's doing it, of course, elegantly as usual.
We stop at 1 turn, but we have not reached it yet.
This is our fix-it.
Yeah, almost.
No, we need the fix-it, the one that fix-it, not live. Okay, because this is my reference.
We need to see the reference.
Yeah, but I need to see it. I need to see it.
I agree. Very crucial.
So this is 1 turn.
Okay. We're
Okay.
going to go live again
Still
now.
halfway to go. Okay. So actually at this level, yeah, we can carry on. Okay. So this is a little bit more than 1. Okay. Almost, guys.
Okay. Yeah, this is, yeah.
This is a little bit more. I think when it
Yes.
goes up, it will be 1.5.
Yeah. Okay. Gonna do one more and see how it is.
We can wait a few seconds. Yes, I think this is almost 1.5. Do you agree, guys? Everyone agrees? It's very good when you have a big crowd and big team and consult them. Better than one eye. So this is very good. So at this stage, we are happy. And we can take our parameters to see how it's behaving now.
Tether mode, we're going to go to the tether mode.
So close the hand, please.
Right hand fixing the blue, and then
the white into the blue.
Now,
excellent. So now we can take some parameters and we can jiggle it a little bit so we can see if we want to see the fixation, if the device is well fixed. Please look at the fluoro carefully, because when I bend down, the device bends with me down. When I go up, it goes back up again. This means that the device, when you jiggle it like this, it's will fix it in place. So now I need the screen please to, on the programmer, show us the programmer, our parameters. If we have a good parameters, we will release our delivery system. So it's, okay, we have a slight rise in the current of injury. Impedance became 770, which is very good marker. And now we will test the threshold.
Dr. Magdy?
No, this is quite fast.
What is that?
Guys,
No.
wait. Just wait. Don't pace now. Wait. Okay. Let the patient is. Yeah. Temporary wire, little bit. Let me just take it back a little bit. Okay. Okay. Just try to pace at 80. Try 80. Okay. Don't pace too fast because. Okay, maybe 90. Go 90 because he accelerated a little bit. The most challenging thing that when we choose this technology, usually you are choosing it for an elderly patient, frail patient, and this is very stressful, to be honest, because you're doing the procedure and the patient has multiple comorbidities. It's not like putting a device in a completely healthy patient with complete healthy anatomy. So that makes it a little bit challenging. But of course, when you do more cases and you try to learn from it, you will gain more. So I think we need to increase the rate again because he's 100 now. So try, okay. Yeah. Yes, please. Yeah, because he's moving a little bit, so his heart rate is building up. Yes, now it's pacing. When you increase the rate to 110 intermittently because he accelerates in between, but it's capturing, it's good. No, don't start, go gradual. So as you can see, we don't want to rush the procedure so quick in order to avoid complication. This is a trick like any other procedure. Just take it step by step carefully and hopefully we will reach to the point what we want. Any questions till we do the testing, then we will show you the release. And I know it's a tough day and long day, but please feel free if you have any questions, we are all ears.
Dr. Mohamed, so I'm wondering whether there is a risk of iatrogenic PVC creation because of the movement of the device. Is it possible, the first one? The second one is, do you have any experience of implantation these devices when there is already device malfunctioned lead, inside? So do you go for extraction first and then leadless pacemaker, or you ignore it and then directly go for leadless in case of malfunctioned leads inside?
Thank you. Two excellent questions. We had cases like this, to be honest. We had a patient who is a lead and she was dependent and she had malfunction. So, and the lead was in the low septum. So actually we put during that time, a micro device in the mid to high septum, and we are planning to do extraction for her. So this makes the extraction much more better to have a backup pacemaker, especially we put it mid to high septum, so it's away from our path for extracting the lead. So, and we have, by the way, 3 cases, because we have been doing leadless pacemaker since 2015 with patient who is battery end of life, and we implanted 2 leadless pacemaker in the same patient. Regarding the first question, which is very good question regarding the PVCs. What you're seeing now is a very complex between the temporary pacemaker, my catheter movement, and the device maneuverability. From what we saw after stabilizing the device, removing everything outside of the patient, you will not see this PVCs coming. If you see a PVC after the procedure, you have to be worried, especially if the patient doesn't have a previous history of PVCs, that the device got displaced and you have to go and snare it. And this will take me to the second point, that from Abbot you have also an extraction snaring tool, which I believe I told Abbot when they showed me the snaring system. This snaring system not necessarily you will use it, by the way, from my experience, I think Dr. Ragid agrees with me,
Yeah.
not necessarily just for the AVEIR. You can use it, it's a very good extraction tool, you can use it for lots of things. You should, I'm not sure it's in the exhibition, but if it's not, I hope they can bring it tomorrow. Dr. Ragid, your input.
Yeah. No, for the PVC, I agree with Dr. Magdy. Actually, it's rarely that you'll see PVCs after the placement of the device. You may get something during, but after we have not seen that. The other thing, we have put an AVEIR in patient who already had a lead in the ventricle. Most of my leads go in the higher septum, so that was not a problem. We put the AVEIR in the low septum.
So now updating you, we have an excellent parameter, so we're gonna release the device. So if you can zoom in on the handle, the releasing system is very easy. It's like, again, it's different from the micro. It's not like a tether and you have to cut it. You see this white knob here? Yes, zoom in please. This white knob, you have just to open fluoro, you have to pull it out. You have to pull it out and just rotation like this. Okay? So now the connection, supposedly, it's disconnected, but sometimes it happens that you have to move the handle a little bit, this white buttons, and you have to shake it a little bit like this. See, once I shaked it, it got separated from the system, and we have the system is getting out. As you can see, once I'm going out, you have more PVCs. Now I can safely take the temporary out as well, because it's, see, when I remove the temporary, the PVC's burden dramatically almost gone. Do you agree with me? And now I would pull the system all the way down till I feel resistance. Please move with me with the table, please. See, I'm taking it all the way down till I feel resistance. This means my system is completely down. This means at this stage, the procedure is actually finished for the AVEIR, but we have to keep an eye on the patient. Don't do the procedure and discharge the patient just like this in the next morning. We have to feel close follow-up for the puncture site. Remember, this is a 27 French sheath, so this is very important. This is an elderly patient. So from our experience, we came to know that we have to keep them hydrated because they forget to drink. We have to make sure the compression is not a lot to avoid DVT. And it's the same thing, we have to monitor the patient by two things in the morning. Programming of the device to make sure that the stability of the parameters is good. They are doing testing again now. And at the same time, after the programming, we do echo to make sure that there is no effusion now and tomorrow morning, and everything is good, we can discharge the patient. So what is your strategy in Saudi?
Mohammed,
We keep them overnight, and if they are stable, we do the echo the next morning, actually, before they go home.
Excellent. And do you close the puncture figure of 8?
I do figure of 8. Do figure of 8.
Okay. Excellent. Any question? Any question about the future upgrade?
May I
Because
ask a quick
I get
one?
motivated about the future upgrade.
Dr. Mohamed,
Yes, please.
so do you, based on your experience, do you need a steerable sheet also to advance your system, especially in case of dilated right ventricles that may make the case easy?
Excellent question. If you can zoom in on this handle, please. We can show it to you. I will take it out. Just 1 second. So we will do it a live demonstration for you, so you can see it actually clearly. So, Dr. Wright, can you do the honors of showing them that? So if you can see the handle in Doctor's right hand, you can actually you can you can actually do some manipulation, not massive manipulation. It's not like the EP catheter, if you're referring to that, but you can see you can rotate up 180, which is quite enough if you're doing such procedure. So it will not go like bidirectional catheter. It's only 180 one direction, which I think it's more than enough. You will not need anything more. So here we are doing this, the figure of 8, and then we will take the sheath out, and the procedure is done. Just fixed his leg. I know, as I mentioned, he's an elderly gentleman with a spine procedure before, and again, he has some sort of chest problem. So we are not doing this, of course, under general anesthesia. I cannot recall we did it to any of our patients under general anesthesia, especially they are elderly, as I mentioned, with multiple comorbidities. So hopefully, when we have in the future the upgrade, we might start doing it more in younger patients. But please, and this is very good to mention because, as I mentioned, this device is upgradable. So if you put it in a patient now, after a few months, you can bring the patient up on follow-up, and if he needs an upgrade, you can put another system in the atrium. So here we tend to compress. If can someone just come and help me here, compress, and we take it. Something else we learned, when you take the sheath, please don't pull it rapidly, because it's a little bit sometimes sticky, and it can harm the vein when you take it. So just take it very slowly. As you can see my hands, very slowly. It might take maybe extra 30 seconds. It's okay. And remaining question, which I find very interesting, and I need Dr. Raid's input. We give, of course, flushing, we give heparin, but do we need to give extra heparin?
I give, after I get the vascular access, I give around, between 3,000 to 5,000. This patient, we did give 5,000.
System is out.
So we routinely do that, yes.
Excellent. We do the same, by the way, because the worst thing can happen that the patient develops DVT post the procedure, and you have to give anticoagulation acutely. So we try to avoid that. So we try the maximum by giving the fluids, hydrating the patient, giving heparin during the procedure, monitor the flushing, and that's it. By that, we finish the procedure, and if any questions, we are here. If no questions, I will see you at the faculty dinner, hopefully, because I'm hungry, to be honest.
Are we going back to the RF case, or we're done?
It's up to the moderator. We can go back. I'm closing. You can just.
It looks like they're done
compression
over there.
Let me check.
Yeah.
We can go for 5 minutes to see what happened. What is the time now? Time?
It's 6:05.
I just 6:05. Okay, I will go for 5 minutes. I know we exceeded our time in the agenda by 20 minutes. Sorry for that, but you can imagine having several live cases. So having 20 minutes.
I think that was amazing. That's